Hello and welcome everyone to another video of our internal medicine board review series. These are questions in nephrology. This is part 4. We are going to discuss electrolyte disorders, and this is also part 2 of electrolyte disorders. Today's discussion is focused on magnesium, calcium, and phosphorus. I am Dr. Mohammed Tinawi. I am a nephrologist in Northwest Indiana. If you would like more information on this subject, please check out my book on Amazon. Follow the link below. Also on this very YouTube channel, there are many YouTubes on calcium, magnesium, phosphorus, and other electrolytes. So let's get started. Question 1. A 52-year-old man presents with muscle weakness and cramps. Past medical history is significant for hypertension and gastroesophageal reflux disease. The patient is on amlodipine, 5 mg daily, pantoprazole, 40 mg daily. His chemistry profile shows a potassium of 3.3, magnesium really low, 1 mg per deciliter, calcium is also low, 7.7 mg per deciliter, albumin is normal at 4.1 gram per deciliter. What is the etiology of his symptoms? Is it A, diuretics abuse, B, laxatives abuse, is it pantoprazole, or is it Gittleman's syndrome? Now, like before, pause the video, think about your answer, because the answer is going to be on the very next slide. The best answer here is C, pantoprazole. So PPIs are associated with hypomagnesemia. Now, I always give test-taking tips. Why is it not diuretics abuse or laxatives abuse? I didn't give you anything to suggest that. The patient is not on diuretics. The patient is not on laxatives. I didn't give you urine studies to steer you in that direction. Gittleman's syndrome, again, I didn't give you his blood pressure, I didn't give you urine sodium, I didn't give you urine calcium, plus he's already on pantoprazole. So the other answers are possible, but they're not the best answer. We're looking for the best answer. So as a general strategy, don't overthink the answer. You'll get it wrong. Here, the obvious answer and the correct answer is pantoprazole. We see that almost daily. So PPIs lead to magnesium loss. The mechanism is gastrointestinal loss, not renal loss. Why? Because they reduce the acidity, therefore they reduce the absorption of magnesium via downregulation of TRPM6 channels, okay? TRPM6 and also TRPM7 channels. Hypomagnesemia can also cause low potassium and low calcium. And how do we manage that? Well, we put them on magnesium oxide. This is probably the best replacement. You start with 400 milligrams twice a day, and you go from there. That's it. Question number 2. A 69-year-old man with heart failure with reduced ejection fraction or chronic systolic heart failure. Left ventricular ejection fraction is at 20%. The patient presents with a creatinine of 0.8 milligram per deciliter. Potassium is a little bit low, 3.4 milliequivalents per liter. Magnesium is low at 1.4 milligram per deciliter. Medications: lisinopril 40, furosemide 40 twice a day, and carvedilol 25 twice a day. What is the best next step in his management? A, stop furosemide. B, add amiloride. C, add spironolactone. D, add dapagliflozin because he has heart failure with reduced ejection fraction. E, start oral supplementation of magnesium and potassium. What is the best next step? So pause the video, think about your answer, and the correct answer is add spironolactone. Now, you're not going to discontinue furosemide. He has heart failure. You can put him in heart failure. Amiloride is not a bad answer. It's not the best answer. Spironolactone reduces morbidity and mortality in patients with heart failure and reduced ejection fraction. We don't have that data with amiloride. Dapagliflozin, you can add that, but it will not correct, we probably should, but it will not correct the hypokalemia and hypomagnesemia, while spironolactone would do that. And you can start oral supplementation, but this means more pills, and supplementation is not going to reduce morbidity and mortality the same way spironolactone does. We've known this information for a long time. So the landmark study in the New England Journal of Medicine, 1999, check it out if you're not familiar with it. Spironolactone helps ameliorate hypokalemia and hypomagnesemia resulting from other diuretics like thiazides and loop diuretics. Spironolactone lowers morbidity and mortality in patients with heart failure and reduced ejection fraction. Question number 3. A 56-year-old man with end-stage renal disease on chronic hemodialysis for 5 years has been using a variety of over-the-counter medications for constipation. He presents to the emergency department with lethargy, confusion, and blurred vision. Neurological examination was remarkable for absent deep tendon reflexes. What is the best next step in his management? A. Do we order a urine drug screen? B. Do we do an MRI of the head given the neurological findings? C. Do we do a chemistry panel including magnesium? D. Do we check a blood salicylate level? You can pause here for a second, think about your answers. And the best answer is to order a chemistry panel including magnesium, because I gave you some clues. Over-the-counter medications, milk of magnesia is really popular for constipation. It has magnesium, and absent deep tendon reflexes are characteristic of magnesium toxicity. Urine drug screen is not a bad idea, but it's not the best answer. MRI is very expensive, may not be available right away, and it is not going to give you the answer. Blood salicylate level, well, also it's not a bad idea in someone with confusion and lethargy, but also will not give you the best answer. And the best answer is to do just simply a chemistry profile with magnesium. If you order it stat, you'll have your answer in 30 minutes. So like I just said, milk of magnesia is used commonly as a laxative. In this patient, magnesium level was a whopping 8.3 milligrams per deciliter. Remember, a normal magnesium is about 1.8 to 2.4. The patient was taking a large amount of milk of magnesia, which contains magnesium hydroxide. Now, what did we do? We gave the patient 0.9 saline for hydration, like you would do with hyperkalemia. We gave him a gram of calcium gluconate, which antagonizes the effect of magnesium. And since this is a hemodialysis patient, we just dialyzed the patient. If you dialyze the patient for 4 hours, then you remove about half of the magnesium. So it dropped to 4.8, which is a much better level. Question number 4. A 45-year-old woman is undergoing chemotherapy and immunotherapy for metastatic colon cancer. She presents with a magnesium of 0.9 milligram per deciliter. Which of the following medications is more likely to result in severe hypomagnesemia? Is it fluorouracil? Is it irinotecan? Is it oxaliplatin? Or is it cetuximab? So pause the video, think about your answer. Here, clearly, the answer is cetuximab. In this patient, she was actually getting intravenous magnesium, 6 grams IV, twice a week, plus oral magnesium, 800 milligrams twice a day. And yet, her magnesium was low. She required hospitalization. And actually, what we ended up doing is to take her off the cetuximab and find an alternative, because there was no way to keep up with this profound hypomagnesemia. So remember that this medication, this immunotherapy, cetuximab, is a powerful agent for lowering magnesium. So what's the mechanism here? Cetuximab is an epidermal growth factor receptor inhibitor. Now, most of the absorption of the magnesium, about 70%, happens in the loop of Henle. unlike any other electrolyte. Okay, so the EGFR, the epidermal growth factor, is really expressed in this area. When you inhibit it, you inhibit the TRPM6 channel, and therefore the magnesium reabsorption doesn't happen, and this is why you get profound hypomagnesemia. Let's go on to question number 5. A 59-year-old woman with a known history of squamous cell lung cancer presents with weakness, nausea, vomiting, constipation, abdominal pain, polyuria, and dehydration. A lot of symptoms. Sodium 144, potassium 3.4. Calcium is extremely high, 16.3. Magnesium is normal at 1.9. Phosphate 4.6. Creatinine is up to 1.9. She was started for this hyperkalemia on 0.9 normal saline at 150 ml an hour. What is the next best step in her management? Do we give intravenous furosemide? Do we give cinacalcet? Do we give pimidronate? Do we give calcitonin salmon? So you have to choose the best answer, because all of these medications would lower calcium. But what is the best answer? So pause here for a second, and the best answer is C, pimidronate. So why is that? Now, intravenous furosemide really has fallen out of favor. So you give hydration first, and if you must use it, you can use it, but you don't start with that. It's not terribly effective. It can lead to dehydration. The creatinine is already high. You can see that the sodium is up, potassium is low. It can worsen the hypokalemia and the hypernatremia. Cinacalcet would lower calcium because it lowers PTH, but it's not going to work fast, and this is really severe hypercalcemia. The right answer is pimidronate. The problem with pimidronate, you have to be really careful with the high creatinine. So you hydrate first, get the creatinine lower, and then you use pimidronate. The dose is 30 milligrams, 60 or 90 milligrams. But in patients with elevated creatinine, you have to infuse it slowly, okay, not over like 20 minutes or 30 minutes. Go 2 hours, 4 hours, really slow infusion and lower dose. I wouldn't use in a patient like this more than 30 milligrams. Why? Because there has been association with collapsing focal segmental glomerulosclerosis, so we don't want that. Salmon calcitonin really has fallen also out of favor. It is expensive, not very effective. After 3-4 doses, you get antibodies, so we rarely, if ever, use it. Someone might say, what about denosumab or Prolia? Yeah, I would love that choice, but this patient was hospitalized, and this medication is expensive. It's used outpatient for osteoporosis. The hospital will not get it for you. If they do, then by all means use it, because it's probably safer for the kidneys. Question number 6. A 43-year-old woman was found to have a serum calcium of 11.1 milligram per deciliter. So this is high. The upper range of normal is about 10.1. This was found on a routine chemistry panel. The patient's renal function tests and electrolytes are unremarkable. The patient has no history of kidney stones and no history of osteoporosis. The next step was to do a 24-hour urine calcium, and that was 21 milligrams, so that's low. Intact PTH level was a little bit high at 60 pg per ml, so the upper range of normal is about 50-55, so this is a little bit elevated. Now, 25-hydroxyvitamin D level was normal at 31 nanogram per ml. What is the next step in her management? A, you order a parathyroid nuclear medicine scan. B, you order a parathyroid ultrasound. C, surgical referral for parathyroidectomy. D, genetic testing for the calcium sensing receptor gene. So think about your answers, and the correct answer is D, genetic testing for the calcium sensing receptor. So what's going on here? The patient has elevated calcium, but she really does not have primary hyperparathyroidism. She has no symptoms, no kidney stones, no osteoporosis. Moreover, urine calcium is low. So any parathyroid surgeon would really hesitate to take someone to OR with low urine calcium. Moreover, if you do a parathyroid scan or if you do an ultrasound, you're not going to find a parathyroid tumor. So you would expect hypercalciuria in primary hyperparathyroidism symptoms, muscle aches, bone aches, osteoporosis, kidney stones, etc. Now, the confusing thing about what she has, which is familial hypocalciuric hypercalcemia, or FHH, is the PTH. The PTH can be up a little bit. So when the PTH is a little bit elevated, the confusing thing is, well, she's hypercalcemia, so the normal response, the PTH should go down. So the fact that it did not go up makes you think of primary hyperparathyroidism. But again, the big clue is urine calcium. Now, family history, well, it's not easy to get patients to know their calcium of their relatives and parents. So what do we do? In this day and age, we do genetic testing. It's easy, it's fast. You just need a blood sample or even oral swab. And here the problem is the calcium sensing receptor. You have inactivating mutation. Okay, so an inactivating mutation in the calcium sensing receptor would cause this condition. This condition is benign, definitely does not require surgery. The only way to make the diagnosis is by genetic testing, which nowadays is available. So really the objective of this question is to distinguish primary hyperparathyroidism from familial hypocalciuric hypercalcemia. Question number 7. A 55-year-old woman presents with chronic hypocalcemia, so serum calcium 6.5, ionizes 3.2, so you know it's proven. And here we're giving you the diagnosis as primary hypoparathyroidism. Intact PTH is low, like you would expect with primary hypoparathyroidism. Serum phosphorus is 3, magnesium is 1.9, so both are normal. 25-hydroxy-D is low at 18 nanogram per ml. So in addition to replacing vitamin D, 25-hydroxy vitamin D, how would you manage this patient? Do you hospitalize the patient to give intravenous calcium chloride? This is option A. B, you give calcium carbonate 1,000 milligrams every 4 hours, and you titrate to achieve normal blood calcium level. Is it C, you give calcium carbonate 1,000 milligrams 3 times a day, and you titrate to achieve blood calcium level in the low normal range? Or is it D, you give calcitriol 0.5 microgram daily? Calcitriol is 125 dihydroxy vitamin D. This is the renal form of vitamin D. So pause here for a second, think about your answer, and the best answer is C. Why is that? Well, there's no need to hospitalize the patient. She's not having a lot of symptoms. And even if we do, we usually give calcium gluconate, not chloride. So that's not the best option. It will solve the problem temporarily. We need a long-term strategy. B, if you do that and you normalize calcium, you're going to have kidney stones. So that's not a good answer. C is the right answer. You want to give enough calcium and vitamin D to keep the calcium in the normal range. D is part of the strategy, but it's not enough in and of itself. So again, keep calcium in patients with primary hyperparathyroidism in the low normal range to avoid nephrolithiasis. Encourage high calcium diet, so dairy products, replace vitamin D. This patient was given 1,000 milligrams actually every 6 hours. We added calcitriol 0.5 microgram daily. Ergocalciferol was given, so this is the 25-hydroxy vitamin D replacement, 1.25 milligram weekly for 6 months and then monthly. And 1 month later, calcium was up to 8, so this is low normal. You don't want it higher than that. Phosphate was 3.1, and she was kept on the same regimen. Question number 8. A 65-year-old hemodialysis patient was found to have a serum calcium of 6.8 milligram per deciliter. Ionized calcium was also low, 3.3 milligram per deciliter, and that was found on the monthly dialysis labs. Now, the previous month, her serum calcium was 9.1. She indicated that her rheumatologist has given her a subcutaneous injection for severe osteoporosis. She didn't know the name of the medication. How would you manage her hypocalcemia? A. Start calcium acetate 667 milligram tablet orally once a day with breakfast. B. Admit the patient to the hospital for calcium gluconate infusion. C. Check serum magnesium. D. Increase calcium in the dialysate, increase the dose of calcitriol, and start the patient on calcium carbonate. You can pause here for a second, and the answer will be on the next slide. The correct answer is increase calcium in dialysate, increase the dose of calcitriol, and start calcium carbonate. Answer A is incorrect. Only 667 milligram of calcium acetate a day, which is a phosphate binder, isn't going to correct her hypocalcemia. Admission to the hospital is an overkill, and she doesn't have that much symptoms, so you don't need to admit to give calcium gluconate infusion, so it's not the best answer. Checking serum magnesium is not a bad idea. Hypomagnesemia can cause hypocalcemia, but that doesn't explain the connection with the subcutaneous injection. So the correct answer is D. Why is that? The patient actually was given denosumab or Prolia for osteoporosis. This is a monoclonal antibody that targets the NF-kappa B ligand or rank ligand. Now, this medicine is very effective in lowering calcium. So it's a great medicine for osteoporosis. You can use it even in patients with chronic kidney disease, but can result in severe hypocalcemia, especially in patients with advanced chronic kidney disease. So this patient was given oral calcium carbonate. Calcitriol was increased from 0.25 to 1 microgram PO daily. And we increased dialysate calcium from the usual 2.5 to 3 ml equivalent per liter. Hypocalcemia resolved after 3 weeks. Question number 9. A 55-year-old man who is on chronic hemodialysis presents with a phosphorus of 7 milligram per deciliter, so it's elevated. This was his first phosphorus, his first monthly laboratory panel. The patient also has iron deficiency anemia. So we restricted dietary phosphate to 1,000 milligram per day. What is the best next step in the management of hyperphosphatemia? Do we give which binder? That's the question. Is it calcium acetate? Is it ferric citrate? Is it Savalmer carbonate or sucroferric oxyhydroxide, or also known as Vel-4? So what is the best binder for this patient? All of those are binders, so they will all work, but which one is the best? So you can pause here for a second. The best binder is ferric citrate because this medication will provide both iron and binding of phosphorus. Sucroferric oxyhydroxide is not absorbed, so the iron in that compound is not absorbed. The other binders are fine, but they do not provide iron. So phosphate in the diet should be restricted to below 1 gram. Increasing dialysis time definitely will remove excess phosphorus, but most patients are reluctant. So we need to use binders in most patients. So ferric citrate is reasonable, 2 tablets 3 times a day with meals. Keep in mind that the tablet is 1 gram and each gram contains 210 milligrams of ferric iron. So when you give ferrous sulfate, it contains 65 milligrams. So this is 3 times as much per tablet. So if you're giving 6 tablets a day, this is a whopping dose of iron. So it's very effective. Fortunately, it's also well tolerated because of the citrate. So it's much better tolerated than, say, a ferrous sulfate, and much more expensive. Question number 10. A 60-year-old woman is on mechanical ventilation due to bilateral bacterial pneumonia. Weaning her off the vent has been difficult. Labs: creatinine 1.5, sodium 144, potassium 3.4, calcium 9.1. Phosphate is really low at 1 milligram per deciliter. So this is why she's difficult to wean, because she's hypophosphatemic. This is weakening her respiratory muscles. So how do we replenish her phosphorus? A, K-Phos neutral, 250 milligram via NG tube 3 times a day. changed to feeding formula from Nepro, she's on a renal formula due to a creatinine 1.5, to Pulmocare, which is a more of a pulmonary formula, and it's not restricted in phosphorus. Now C, give potassium phosphate 30 millimoles IV over 4 hours and repeat until phosphate repletion. D, check 25-hydroxy-D and replace if deficient. So you can pause the video, think about your answer, and the correct answer is on the next slide. It is C. Why is that? A is not a bad option, but it's going to take you a while, and her serum phosphorus is really low, so oral replacement is not enough. Plus, it's going to be through NG, and sometimes you can crush certain things, other things you cannot. Changing the tube feeding formula is something you have to do, but it will take a long while for phosphate to correct. Checking 25-hydroxy-D is not a bad idea, and probably it is low, but again, replenishing D and hoping that you increase intestinal absorption of phosphate, that will take a while. So the correct answer is to give potassium phosphate. Why not sodium phosphate? Well, because her potassium is also low, so you're replacing both. So you're giving potassium phosphate 30 millimoles IV over 4 hours, so don't give faster than that. And then you check the phosphorus, and then you keep repeating. You give 15 to 30 millimoles over 2 if it's 15, 4 hours if it's 30, until phosphorus is 2 to 2.5, then you won't have problems anymore. So hypophosphatemia weakens respiratory muscles, making weaning off mechanical ventilation difficult. This patient was replenished with K-phosphate. You can also use sodium phosphate, but here again the potassium was low, and we keep repeating until the patient is replenished. Phosphate should be added to the TPN and adjusted if the patient is on TPN. If they're on a renal formula like Nepro, they should be changed. And we should avoid, like I said, low phosphate enteral nutritional solutions. The correct answer is checking FGF23, fibroblastic growth factor 23. Other tests you probably should do anyway, but will not give you the answer, so it's not the best answer. So this patient has tumor-induced osteomalacia. Okay, it was suspected. This is why an abdominal CT was done, and then a mass showed a mesenchymal tumor. So the tumor produces FGF23. Now, in specialized laboratories, you can actually order that test, and it came back very high at 402 RU per ml. The tumor was resected. The final diagnosis was phosphaturic mesenchymal tumor mixed connective tissue type. After surgery, the patient's serum and urine phosphorus, in addition to alkaline phosphatase, calcium, and FGF23 levels all slowly returned to the normal range. Last question, number 12. A 15-year-old boy presented with rickets, multiple skeletal deformities, and osteomalacia. Laboratory evaluation revealed hypophosphatemia, hyperphosphaturia, low 125 dihydroxyvitamin D3 level, and elevated serum level of FGF23. What is the likely diagnosis? Is it 25-hydroxyvitamin D deficiency? You know that vitamin D deficiency can cause osteomalacia. Is it lead poisoning? Is it X-linked hypophosphatemic rickets? Or is it Paget's disease? You can pause for a second. The correct answer is X-linked hypophosphatemic rickets. It's the only disease mentioned that gives you all that, especially elevated FGF23 level. And here you have renal wasting of phosphorus. Additionally, you have low calcitriol level or 125 dihydroxy D3 level. So in this patient, the diagnosis is X-linked hypophosphatemic rickets. This is X-linked dominant. It is responsible for more than 80% of cases of familial hypophosphatemia. It causes loss of function mutation in the PHEX gene. This causes a rise in FGF23 level and renal phosphate wasting. Why should we know about it? Again, now we can confirm the test easily with genetic testing. It causes more than 80% of familial hypophosphatemia, and we have a treatment. Bermesimab is a recombinant human monoclonal antibody that blocks FGF23. I hope this was useful. Please comment, subscribe to the channel, and like the video. See you later.